Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. Today's briefing will address recent COVID-19 surges across the country and emerging outbreaks of monkeypox. We'll discuss testing and vaccine strategies, updates on treatments for COVID-19, preventing continued outbreaks, and recommended congressional action to prepare for future pandemic threats. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. First, I'd like to briefly introduce our speaker. Dr. Tom Inglesby is the director of the Johns Hopkins Center for Health Security and a professor in the Department of Environmental Health and Engineering at the Bloomberg School of Public Health. His work is internationally recognized in the fields of public health preparedness, pandemic and emerging infectious disease, and prevention of and response to biological threats. Dr. Inglesby returned to his role at Hopkins in April after serving as a senior advisor on the White House COVID-19 response team. We will have time for questions following our speaker's remarks. The procedure will be as follows. We will take some questions that have been submitted in advance of the briefing and some from the Zoom chat. If you have a question during the briefing, you can enter it in the Zoom chat addressed to all panelists. Please enter your name, media outlet, and question. We hope to cover as many as possible. Just a note that participants will be muted during this briefing and it will be recorded. Dr. Inglesby, please go ahead.
Well, thanks very much, Ellen, and great to be with you all. And I will start with just a few big points that I want to make, and then, of course, turn to your questions. So the first point I want to make is that we do seem to be at a national plateau in a surge driven by Omicron subvariant B.1.2.1. And it is good news that these numbers seem to have plateaued nationally. But the big point here is that it's important to see how much work remains to be done to diminish the impact of COVID, and to see that COVID is still posing a substantial threat to health and life for many, many Americans. So within that point, it's good news in that the Northeast and Midwest cases are declining, and that overall hospitalizations have risen in this surge much more modestly as compared to past surges. And it's of course really good news that deaths have not risen in the way that they did during the Omicron surge, when they were really considerably higher than they are now. But it's concerning that cases in the West and the South are still rising. Hospitalizations nationally are still rising. And there are still about 265 deaths on average a day across the country from COVID, which makes it still, even at this point, somewhere around the 8th or 9th leading cause of death on a weekly basis. And cases caused by subvariants, Omicron subvariants, BA4 and BA5 are rising. And so it's possible that they themselves could lead to some level of surge beyond what we see now, or at least slow down the return to a lower baseline of cases. It's too soon to say whether that will happen, but we have seen that BA4, BA5 have had a big impact in some other countries in the world. It's also a big concern that a third of the country is not fully vaccinated, and only 1/3 of the country has had a booster shot. And we know that full vaccination and boosting reduces serious illness, hospitalization, and death. And compared to many other peer countries, our vaccination and booster rates do not measure up well. This means a large unvaccinated and/or unboosted portion of our population remains quite vulnerable to serious COVID infection, and that's in addition to people who are immunosuppressed, whose vaccination may not provide the protection it provides to the immunocompetent. It's not too late to get vaccinated and boosted. If you haven't been vaccinated yet, now is the perfect time to do it. And while we have many tools to cope with COVID, we have vaccine, treatment, testing, masks, We have improvement in ventilation in some parts of the country, some buildings. We need congressional support to sustain those tools. Funding to develop new vaccines, to cope with variants, to fund treatments, to fund testing infrastructure, and international response all needs to come from Congress. The administration has sent a request to Congress for funding many months ago, and Congress has not yet acted on that request. A second big point, treatment is widely available to reduce the risk of dying and hospitalization for the older and for the more vulnerable in our country. It is much easier to get Paxlovid now than it was even 2 months ago. So any person with COVID symptoms, or any older person, I should say, with COVID symptoms, or any person with underlying medical condition with COVID symptoms should get tested as quickly as possible and should get treated, if positive, as quickly as possible. Many COVID deaths are now preventable. So we need to use these treatments that we have to reduce the lives lost to this disease. A third big point, it is very important that the clinical community is considering monkeypox in patients with viral illness and rash across the country, and that we continue to raise awareness that people with viral illness and rash should get seen by their providers and evaluated for the possibility of monkeypox. Monkeypox is still quite rare in the United States. As of yesterday, 31 cases have been reported in the US in 13 states, including Washington, DC. But it's very important for us to continue, the government to continue, for the clinical community to continue to inform clinics, healthcare providers, and to engage with organizations on the ground that work with higher risk communities about the possibility of monkeypox. The clinical community has not really ramped up testing as of yet. Testing is going on, but not at the level it should be as yet. And so we need to keep pushing that clinical information out, that awareness in communities out on the ground, and to try to increase the level of testing that's going on. We should have a really low threshold for doing testing, particularly in communities such as community men having sex with men who've been identified as a population who have been disproportionately affected in this monkeypox outbreak so far, but certainly in others who have viral syndrome with rash, we should have monkeypox on the list of possibilities. We know that monkeypox is typically spread in close person-to-person contact through respiratory droplets or through direct contact with skin lesions on or from bodily fluids such as on bedding or clothing. We know we have a vaccine that is effective as a pre-exposure or a post-exposure prophylaxis. And finally, a last point before I turn to questions, one thing we should take in common from both COVID and monkeypox is that the country needs to do more to prepare for and try to prevent the impact of future epidemics. The president has proposed in his budget, in this year's budget from the administration, an ambitious program over the coming years to try to better prepare for pandemics. And really what I would urge Congress to act on that plan and to support it this year and in the years ahead. So I'll stop there and I'll turn to Ellen for moderation of questions.
Great, thank you, Dr. Inglesby. We'll take questions. Again, if you have a question, please enter it in the Zoom chat with your name, media outlet, question, and to whom you'd like to address your question. So let's start with two questions from Luke Andrews at the Daily Mail. Do you think the latest COVID wave has peaked? Would you say the pandemic is now over?
So as I was saying before, I think we are in what appears to be a plateau. Not all plateaus stay plateaus. We've experienced in the last couple of years times when numbers appeared to level off and then for one reason or another started to go up again. So it's not possible to say that this surge has peaked for sure, but in the Northeast and in the Midwest, cases are beginning to come down. But in the South and in the West, cases are still continuing to go up. Hospitalizations are still continuing to go up. So as in the past, it looks different depending on where you are in the country, but we are not definitely still in the middle of a surge. And your second question is COVID ending or are we towards the end of this pandemic? We are not, unfortunately. We are in a better place than we were a year ago, certainly better than we were during Omicron, but there are uncertainties about the future. There is an expectation that in the fall and in the winter, we will possibly see new surges that may be more serious than the ones that we're in now. So it's far too soon to say that we are rounding the corner with COVID. We have better tools than we've had before. We can continue to drive down the impact of COVID, but COVID is going to be with us for some time into the future.
Great, thank you. Here's a question from Denise Rowland at the Wall Street Journal. There seems to be some confusion about the potential for airborne transmission of monkeypox. What do we know and what don't we know about the potential for airborne transmission of monkeypox?
So monkeypox has been a disease that's been studied for quite some time. It does, the virus that's now circulating does appear to be very consistent with the virus that we'd seen in Africa where it's endemic. And what we know from that disease is that monkeypox spreads at close contact through respiratory droplets, which again are droplets spread at close contact. When you ask a question about whether it's spread airborne, what that means, typically what we're saying when we say that is that can this disease spread at greater distances than close contact? Can it spread across a room in a way where the virus drifts a long distance? And at this point, we don't have any evidence that it is doing that. It appears to be spreading again through close contact, whether through respiratory droplets between people who are very close to each other or through direct physical contact, skin on skin contact, or through contact perhaps with bedding or clothing. I think we're still learning more. This is still a new disease, but the pattern appears to be consistent with that so far. And we're going to continue to learn about it as more of the information about the earliest cases continues to be presented and reported publicly.
Great, thank you. Next question from Julie Steenhausen at Reuters. Today, the CDC for the first time included the percentage of cases caused by BA4 and BA5, and they do appear largely in the West. What do you make of these increases, and would these variants eventually end up back in the Northeast, which had a big BA2 1 surge?
So yes, it is true that BA4, BA5 are now being reported separately from other Omicron subvariants, and it does appear that they are rising fairly rapidly as a percentage of the overall cases in the country, in some regions more than others. And given the data that we've seen so far, I would expect that BA4, BA5 as a percentage of new cases will begin to increasingly replace BA2, 121. We've seen that occur in other countries, but that's not a sure thing. Our country has had and it is still going through a surge of B2, 121, and both of these things are new enough so that we're not sure how much protection BA2, 121 will provide against BA4, BA5. So unfortunately, it's not easy to say whether or not BA4, BA5 will come back and become a big problem in the Northeast, which has just gone through its BA2, 121. It's too soon to say. We've seen places like Portugal have a very, very sharp rise in cases, a big surge generated by BA4, BA5. It's now looks like it's beginning to come down, but it's something we're definitely going to need to track closely. And we're hopeful that the BA2, 121 experience will provide some collective barrier against a sharp rise in BA4, BA5, but we don't know that yet.
Follow-up question, more for you to add any additional comment from Cecilia Smith-Schoenwalder at U.S. News and World Report. What do you make of these subvariants, BA4 and BA5, and what should the U.S. expect in terms of emerging variants moving forward? If there's anything else you'd like to add.
Well, I guess what we can say about BA4, BA5 is that it did seem to have a big impact in South Africa where it caused its own new surge. And then again, we've seen the experience in Portugal. We have not seen it become a generalized problem around the world, unlike, for example, Omicron, where it really affected many parts of the world in a very serious, rapid way. but it is still relatively new. This is still a variant that's only been around for a relatively short period of time. So I think its ultimate impact is still to be seen. We also know that while in the beginning of this pandemic, variants seem to impact the world in a more common way. And as the pandemic has gone on, different variants have had different impact in different parts of the world, probably because of their demographics, the number of people who are vaccinated, the things they already experienced. So I don't think we know a lot about what the BA4, BA5 will do in the US because of all those variables, but the fact that it's rising quickly as a percentage of cases is cause for some concern and certainly close tracking. We just don't know yet how much it will push the peak up.
Great, thank you. Here's a question from Adriana Rodriguez at USA Today. Why hasn't monkeypox blown up the way COVID-19 has? Is it just not as transmissible? How transmissible is monkeypox compared to COVID?
So yes, it is. First of all, it's new. That's one thing. We're just discovering the extent of cases. But much, much more importantly, it is not spread in the same way as COVID. COVID is spread by respiratory droplets and by airborne spread, and had a very high reproduction number or a very high reproductive rate. So each case in an unvaccinated community could cause many, many cases. Here, we're still learning about the pattern of spread of monkeypox outside of its kind of the places where it's been causing endemic disease. But it, again, appears to be spreading by close contact and is not affecting groups of people, not acting in a way like a disease that spreads through respiratory droplet or airborne dominantly does. So it's not acting like diseases that we have experience with. It's not acting like influenza or COVID or chickenpox or measles, things that spread quickly in an unvaccinated community. It's acting much more like a disease that requires close contact, and that is going to spread more slowly. It doesn't mean it's in any way an unimportant disease. It could cause great trouble in the world, particularly in vulnerable communities, particularly in lower income countries, which have less tools to cope with it. So it's really important to do everything we can to try to control it, but we're not going to see the same kinds of early numbers as we saw with COVID because it's moving around in different ways.
Great, thank you. A question from Drew Armstrong at Bloomberg. Is the current testing capacity for monkeypox sufficient? Where are the bottlenecks, and how comparable is this to COVID testing in February, March of 2020?
There is a substantial amount of unused testing capacity in the public health lab network system. There was a White House and CDC briefing on Friday where they described really only accessing about 1% of national capacity in the public health lab network system as of last week. That has changed probably a bit in the last few days. But that being said, it does not appear that there are a substantial number of monkeypox tests being ordered yet by the clinical community around the country. The overall numbers of tests have not been very high, and that likely relates to clinicians just becoming familiar with this disease and with the process of testing. I think that will get better, hopefully quickly. The more that the clinical community learns, the more that people who are deem themselves to be at risk, or in particularly vulnerable communities, are presenting and perhaps even saying, I want to be screened for monkeypox. It's kind of a engagement at the clinical level, engagement at the ground level, engagement by healthcare providers and by public health departments. I think we have capacity. I think the next logical step to add to that capacity is to bring monkeypox testing to the private normal lab networks that are used around the country. It's important to use the public health lab network that exists, but it's also important to get it into the routines of normal clinical practice around the country. And I know that CDC and ASPR and HHS are working with the laboratory network, the private sector labs to try to get that to happen.
Great. Now back to COVID. Questions from Grace Wade at New Scientist. Should we continue to try and curb the spread of COVID-19? If so, what policies should the government consider enacting to do so?
Yes, we should continue to curb the spread of COVID-19. This is a virus we've seen can obviously causes a great deal of morbidity and illness and mortality, and has really, we're still understanding the impact of long COVID. It may be as many as millions or tens of millions of people affected by this that have persistent symptoms beyond the acute illness. And so we should be working to try to prevent people from being infected from COVID. And our tools, our best tools, are vaccine and boosting. And as part of that, we also want to do whatever we can to prevent especially people at highest risk from getting exposed to COVID. So people who are at high risk, especially those who've not yet been vaccinated or boosted, making sure that they use masks or avoid indoor places where they're going to be at high risk. We also should be doing what we can to improve ventilation in common spaces, common indoor spaces, so that as people continue to come back to work and continue on with school and university and other events where we're inside, that we reduce the risks through practices that we know will lower the level of virus in the air in these places, and that's improve ventilation. So there are things that are getting done and that need to keep going. And for almost all of those things, there will need to be continued federal support from Congress to continue to pay for the evolution of vaccine, to make sure that vaccine can match the variants that are ahead, to make sure that we have treatments available for people, to make sure that we have a testing infrastructure that doesn't stop at a certain time because it runs out of money. All of those things are going to be contingent on continued federal funding.
Great, thank you. Questions from Kimberly Wyatt at WEAR TV in Florida. What could COVID look like in the future? Will it just be another virus like the flu?
Yeah, I don't think we can, we don't know the answer to that yet. One possibility will be that as people get vaccinated and boosted over time, that there is more enduring immunity, and that the level of illness caused by COVID for the average person living in America becomes less and less sickness, much less death, and that it becomes a disease that we need to be vaccinated against once a year or more frequently. So it is possible that it moves in a direction which is lower impact, not zero impact. That's not at all possible in the near term. For people who are unvaccinated and boosted, it's going to remain a serious health threat. It is also possible that it will evolve in ways that are challenging, new variants that emerge that require either different vaccine or boosting to protect people after fading immunity. Just remembering last year, going into the summer of 2021, we did not see the Delta wave coming by more than a few weeks' notice. And similarly with Omicron in December of 2021, that was also not on anyone's screen before a few weeks when we began to see what was happening in South Africa and then in Europe. So I think for people who make predictions beyond a few months, I think that's pretty difficult to do. I think what we need to do is to continue doing what we're doing, continue to encourage vaccination and boosting, provide people information, understand why they may not be interested in pursuing those interventions, and try to keep moving the needle on that, and making sure that Americans have access to the tools they need to protect themselves, treatments and testing and masking, and that institutions work to improve their ventilation. And we need to be ready for future variants or surges should they occur. We can hope that they won't, but we need to prepare as if they will occur, including what we've seen in the last couple of years, fall surge, winter surge. We hope that they won't keep happening, but we need to prepare as if they will.
Great, thank you. A question from Alex Knapp at Forbes. Is there an expectation that there might be a summer surge in the South again, like we saw with Delta, especially with BA4 or 5 on the rise?
I think we should have an expectation that particularly in the South, we will see numbers rise again, which we've seen in the last couple of years. We believe that in part that relates to people moving indoors, air conditioning, less ventilation than they had before in the spring months. We have just experienced this rise of Omicron subvariant 121. And so it is possible that recent experience with that, plus the relatively recent experience with Omicron, changes the way the summertime looks and that we don't have a similar experience. It's also possible that BA4, BA5, which are rising in proportion, could create a surge on top of a surge. But it's very difficult to know this because we don't really understand whether the immunity provided or the collective experience provided by BA2121 will protect in any general way against BA4, BA5. So I do think we should be prepared for a summer surge, but somewhat hopeful that it won't have the same impact as it has in the past because of our experience this year, because of additional vaccination and boosting, but we should be ready for one.
Great, thank you. Here's a question from Sonia Assad at WFAA TV in Texas. When do you anticipate that second boosters, fourth shots, will be open to Americans under age 50?
I think the federal government is continuing to study that and to try to continue to make a risk-benefit assessment. When do they see any kind of data that suggests that that would provide a benefit for that age group? I think probably we'll continue to see an opening up of that because we know that over time, the advantages provided by a booster will fade. And so many more people who have gotten over time, people who got boosted in the wintertime will be far enough away from their booster that they will be less protected by it. So I suspect we will see an opening up of a fourth shot or a second booster in the time ahead, but we'll have to see what the federal government, kind of the review of the data shows.
Great. And here's the last question, a follow-up from Sonia Assad at WFAA. What do you say to people who say there's no need for a COVID booster since they'll probably get COVID anyway?
Well, what I would say is that we have evidence that the first booster, and then for over 50s, the second booster prevents infections, and it is far better to get immunity through vaccination and boosting than getting it through having to go through an infection. Many people have gone through an infection in this country, but they should not take from that they are therefore fully protected from a reinfection. We have data that shows that people who are infected and then get vaccinated or who have been prior vaccinated are better protected than those who are just infected alone. And when you do get infected from COVID, even if you recover quickly, you are still at some risk of developing long COVID. And we don't want people to be at risk for long COVID. It's very difficult to predict who is at risk for long COVID. We have some information, but people who had prior good health status and recover quickly from COVID can get long COVID symptoms. And so the bottom line is that vaccination and boosting increases your likelihood of avoiding that, decreases your chance of getting a COVID infection. And so we really want people to get vaccinated and boosted to avoid the possibility of COVID infection and long COVID that could follow.
Great. Thank you so much to Dr. Inglesby for your presentation and insightful answers. We will email links to the resources mentioned today and share it in the chat. And with that, I'd like to say thank you again to everyone for joining us today.
Thanks so much.